at the Cardiovascular Summit here in Orlando. We're going to talk about chest pain centers for a moment. I am with Richard Chazal, who is Medical Director at Heart and Vascular Institute at the Lee Memorial Health System and Vice President at the American College of Cardiology. This was one of the last sessions on the last day, and it was great because it covered a variety of case studies. You talked about chest pain centers. What were you talking about?
Well, we were trying to provide some practical notes, at least in terms of case study format, about how to do this sort of thing. And really the overarching theme is, how do we begin to develop systems of care that utilize the cardiovascular care team to improve quality and efficiency and begin to move us from the volume to value equation. In our particular case, we were utilizing a case study of trying to improve the care of patients who arrive in the emergency department with chest pain but are not clearly having a heart attack. And in these cases, we are trying to very efficiently work through a process of care that analyzes what's happening to them and then safely get them taken care of, either in the cath lab or by going home or a stress test or whatever is needed, but utilize the types of resources available in terms of guidelines and appropriate use care to do this.
And you did an interesting study to look at just exactly how you impacted stay.
We look at a number of metrics, and one is how long it takes to work through that care pattern or length of stay. And in this particular case, this is one of the places where as a clinician I actually do like length of stay as a metric, because we're accomplishing the same care within a shortened framework, which for the patient is terrific because he or she is spending less time in PO, not eating and hungry and scared, quite frankly, right, before there's a definitive diagnosis made and then they can move on. From the hospital standpoint, it frees up beds. And so that leads to our other metric, and we've actually looked at the number of bed days saved. In our system, a 4-hospital system, beds are at a premium. We're oversubscribed, and often there are a lot of patients in the emergency department who are waiting for care because we can't clear out the beds up on the floor. So by shortening the length of stay and increasing the efficiency of the evaluation of the patient with chest pain, we're freeing up bed space for the person with a broken leg, and we believe that that's impacting the care of the community.
You found an interesting halo effect.
Yeah, it was very interesting because what we did is we utilized a protocol based on appropriate use criteria and guidelines to try and improve care. And I should note that this is driven also by having really good advanced care providers on the team that help lead the effort from the front end. And we found we cohorted the group that were cared for in that particular process with that care team in place versus those that had the more traditional care for chest pain. And we found that the length of stay for both groups dropped. It dropped more for the group that was in the cohort cared for by the advanced care provider, but the group that weren't cared for by the advanced care provider also improved in our institution. We believe that that was increased utilization of this guideline-derived protocol that abbreviated some of the wasted time that we had before.
They kind of learned what you were doing and decided, hey, I'm going to do that.
Exactly. And so
I'm going to do that on my other patients.
Exactly. So what I would do for my patients is when I was on call for the chest pain center, I'm utilizing the protocol. And then the next day I'm not on call for the chest pain center, and one of my own patients comes in and I say, gosh, that really works extremely well. I'm going to utilize the same protocol. So that halo effect or spillover has been beneficial to all of our patients who arrive in the emergency department.
I think a lot of facilities, a lot of centers think that they are already following the guidelines and all of that, and so that there's no improvement to be had. How do you know that you actually need to concentrate a little more on this and impact what the numbers are at your center?
I think every facility is different, and we're all on a spectrum of how well we're doing, and we're still consider ourselves on a continual learning curve. So the data that I showed you today is not good enough. We need to improve further. But I think all of us have room for improvement in care and look for those gaps. But I would also say that looking at data is how you begin this process. Our initial data set had showed that we had an excess number of patients who arrived in the emergency department who had nuclear stress tests that ended up being negative. and we saw that there was an opportunity there for more appropriate utilization of resources, reduction in exposure of patients to radionuclides, just better care. And as we did so and marched through utilizing that data as a benchmark, we were able to show an improvement.
So assume you can do better.
I think we always can do better. I haven't found any system yet that I thought was perfect, and I think that that's part of the entire mindset of most cardiologists and cardiovascular specialists and the care team in the country, is that if I think I'm really good at what I'm doing, there's a tremendous opportunity to get better tomorrow. And I think that's one of the exciting things about being in cardiovascular medicine right now, is that tomorrow's a new day and you have an opportunity to do things a little bit differently and a little bit better. There's no reason to ever get bored.
And that's the part about the CV Summit that makes it exciting, is there are all kinds of areas where you can improve. And the CV Summit, with this whole changing of the industry as it moves to a value-based system, there are so many new things to do.
It's very exciting, and there are new things to do. And the other thing that I find fascinating is that the innovative changes come from all over the country. They don't come from just certain centers. So we've got people all over the country that are really, really smart, who've come up with ways to improve care and really deliver care to these patients in a better way. So we're learning from each other. And I was commenting earlier today, there was a talk given by Menno Walsh from Indiana, who's a heart failure specialist, an area that I thought I knew a fair amount about, and I went through a bunch of pieces of paper, taking notes as frantically as I could to utilize some of the input that I got from her.
Well, we have a lot of the information from the CV Summit that's going to be a part of our cover story in CardioSource World News, so please check that out. I am CSWN and Executive Editor Rick McGuire.